have published my own study on 22 gauge needle and endoscopy. So you can take a look at that as well. So majority of those are being done now is 19 gauge core needle, and you can get really a good core tissue. The biggest problem with the liver biopsy, EUS guided liver biopsy, is which was happening was main thing is you need an intact core. That's what they get with the percutaneous. Okay. With the EUS, what we were having a trouble in the beginning is like how to have an intact core, especially with the FNA needles. Then came the FNB needles, and that it became possible to get a core tissue. So there are some studies on 19 gauge needle. You can get a long core as long as like 3 to 5 centimeter on that. Then there was no prospective study really just on FNB needle. There was one that was a sharp core needle, 22 gauge core needle. They were not able to get a good core tissue with that, and like a long core tissue. You have to remember, it's not just you're not making a slide with a liver biopsy, parenchymal disease I'm talking about. You're not just making a cytology slide on that. You need a intact architecture. They need a minimum of 11 to 12 portal tracts, intact portal tracts or portal triads, what we call, for a pathologist to give any opinion about that. And for that matter, you really need at least 1.5 centimeter long core. So with the 19 gauge core needle, it was possible. There was a study done on 22 gauge core needle, sharp core needle. Didn't give much good tissue as compared to 19. So then there is a acquired Boston 22 gauge needle. So I developed a technique how to get a core tissue. I did some FNBs were having a problem with that, how to keep an intact core, and then eventually figured it out how to keep that. And then I did a prospective study on that, and presented at DDW oral presentation. Then I published in endoscopy, and then editorial on that, and then I have to respond to the editorial as well. I just sent you that a few days ago, and so it's you can take a look at that. So it is possible to get a good core tissue, maybe even up to 3 to 5 centimeter, with the 22 gauge FNB needle as well. And that's mainly, I'm talking about the acquired because that's the only needle I used. And you can get a portal tracts even up to 40 to 50 portal tracts in one core. And the only problem with the 22 gauge FNB needle is, one thing, it's a very, very small, obviously, core in diameter, and it's a little bit crush effect on that. And the pathologist, there's no pathologist here, you even give them a whole liver, they still may not be happy. They still want more specimen on that. So that's what just exaggerating, obviously. But the problem they are having with that is the specimen diameter is really small. It's a needle. How much you expect? It's a small needle. It's not a 16 gauge needle. I think they use 16 in the percutaneous, and 16 and 18 both, yeah. So 18, 19, not much difference. 16 does make a little bit difference. 22 is way too small as compared to them. And so that's a little bit crush artifact, but I had done 40 prospective patient, each patient 3 biopsies, and that comes out to be close to 120 specimens. Every specimen was diagnostic, more like pretty much every 22. And they were able to give a specific diagnosis. Having said that, little bit crush artifact and smaller diameter. And so it is possible to get a good core tissue, viable tissue, studyable tissue with the 22 gauge as well. So that's a totally different topic, really, liver biopsy. But now, yeah, we can do the liver biopsy, a good liver specimen. Okay? So before I go, this talk actually, I don't think I showed these pictures when I was talking about how to perform EUS, when you're performing EUS, about the anatomy and everything. You have seen this this image in the atlas, right? कौन सा atlas है anatomy का कौन सा use? This, I think this picture is from Natters, ठीक है? So if you look at this, if you are looking from the front, this is how the right anatomy looks like, right? You take a look, there's a stomach, pancreas, left kidney, spleen, right kidney. And when you are in the stomach looking at that, this is a EUS image you see. Sometimes it's like doesn't make sense. And you remember I talked about it really depends where your transducer is, which position. But this would really, really make sense to you in just a minute, okay? Have that paper, have that atlas picture right in front of you, and then maybe rip it off the atlas, okay? And flip it over, okay? Just flip it over, okay? When you flip it over, that's exact EUS anatomy, what you are looking at. Okay. So that you can make that map into your head. That's what you are looking at it. So it's really, it was a paper, you just flipped it and looking from the paper. Okay. So here, now this is what you are seeing on EUS. So you see this is a pancreas, pancreatic body, pancreas, pancreatic body. Where do you see the kidney? Right here, right here. Where do you see the spleen? Right here, right here, okay? So this is like complete representation, EUS picture, complete representation in right here. So this is an easy way, this is the station, gastric station, the whole gastric station just looks like that, okay? You can just memorize that, or that would help you a lot to really understand how it's what I'm looking at it and how I'm looking at it. Okay. Next one, this is pretty much same. Okay, this is the other important one. Okay, so if you look at that atlas, you see the pancreatic head is right there, bile duct there, portal vein there. This one you don't have to flip because you flipped your scope. Earlier you were looking from the top, now you are in a longer position and consider you're looking from back upwards. So you don't have to just change anything, just memorize that picture, and this is exactly what it is giving you. Pancreas, bile duct, portal vein. So that's a perfect just copy of the regular image from the atlas. Okay?
This is my view radio.
This is a even with yeah, this is a radio obviously, but the linear you're gonna have the same image.
Slightly
Yeah.
different.
Yeah, you're just gonna take a look, and it's just linear. Obviously, not giving you, it only giving you 120 degrees, not a 360 degree, and so. But concept, even with the linear, is same. Okay. So these two. Yesterday, other question was about the reporting. Okay. So endoscopy report, like a good endoscopy report, obviously you should talk about what type of scope did you use. All of you are going to use a linear scope probably. I don't think everybody has a radial. And should mention about the sedation, what type of sedation. One of the most important thing while you are doing it. So all these should be a component of the report. And then what I say is like, because majority of these, you're going to talk about the pancreas, okay? So in the pancreas, you have to talk about what the parenchyma, this is like a regular, no mass in there. You have to talk about the parenchyma, you have to talk about the duct. If you're doing it for evaluation of chronic pancreatitis, what features are there, how many out of those 9 features are there? Is it high probability, low probability? Then when you come to duct diameter, or the duct itself, what's the diameter? What is the normal diameter of the pancreatic duct? 3. Yes, you can apply that generalized rule. Even up to 4 is fine. Patients on narcotics, sometimes they have a slightly dilated pancreatic duct on chronic narcotics, and they have the dilated bile duct as well. So 3, 2, 1 is the general rule we use. 3 in the head, 2 in the body, 1 in the tail. If it's a mass, talk about the diameter of the mass. How about the boundaries of that? Are they irregular? Are they like well circumscribed? And also its association with the vasculature, if you are able to describe that. Having said that, the CT and MRI, especially the CT scan nowadays, much better technology, especially with regard to vascular invasion and obviously with regard to meds. So you cannot solely depend on EUS itself, and CT is complementary to that. So this is that part. You have to talking about the pancreas. I mentioned about vascularity. Sometimes if it's especially if it's a luminal cancer, because the staging depends on the lymph nodes as well. Not as so much with the pancreas, but the luminal cancer, esophageal, gastric, rectal, you have to mention about the lymph nodes too. And lymph node criteria, usually I hardly ever have done a FNA on those lymph nodes, because usually they are peritumoral. And what I say is like if you're going to do, if the lymph node is just an inflammatory, and you might make it positive by going through the tumor while doing a FNA. So I just take a look at the characteristics of that. And if they look malignant, then I will just put them as nodal staging. So that left kidney, not our specialty. And if you see something really obvious which needs a further evaluation, you can mention about that. Left adrenal is really important, mainly only lung cancer staging, because lung cancer metastasized to the left adrenal. So in those cases, mention about that. With regard to biliary system, bile duct, how that look, what's the diameter. We almost do a diameter, check the diameter of the bile duct from the duodenal bulb or second part of the duodenum. I think that always gives you a, now I shouldn't say always, that majority of the time we don't give the right diameter of that bile duct because you're compressing on it with your balloon or with your transducer. The best area where you can get the diameter of the bile duct is really from the stomach itself, if you can see the bile duct. That would be more representative of the accurate diameter of the bile duct. So talk about that. With the EUS, really we can see the left lobe of the liver and segment 5 of the liver from the duodenal bulb. Beyond that, it becomes really, really difficult. If you see anything obvious, especially with the pancreas cancer, I always take a look at the liver. Spend a minute or 2 minutes on that and look for any metastatic lesion there, because that's going to change the management completely. That becomes a metastatic cancer, so they are not a surgical candidate. So every pancreas cancer which I diagnose during the EUS, I always take a look at the liver to make sure there's no obvious metastatic disease. Okay. Mediastinum, yes.
If you find a mass in the pancreas, and also there are some nodal nodes that may be nodal mets, and there are also lesion in the liver. Will you sample all of them? And if yes, which one first?
So nodal, no. There's no need. That's going to be, there's no purpose of doing that, okay? So the main goal, because they're going to be peripancreatic lymph nodes. If it's a celiac lymph node, that's a different story, okay? So if there is a liver lesion, obvious lesion, and there's a pancreatic mass as well, you really should go to the liver lesion first Because if clinical picture obvious is with the pancreatic one, pancreatic metastatic. So if that's positive, probably it's a pancreatic lesion. But having said that, majority of the oncologists, they want an actual mass tissue as well. So I, in my practice, because the way it is, I end up doing both of those. And nodal, unless it's just a small mass in the pancreas, and then I'm looking at a lymph node in away from that somewhere, which looks like something that doesn't look right. In that case, I might do it, but that's hardly ever that is the case. And for me, I think I don't know you guys here. I think if the oncologist is happy just with the liver lesion biopsy, overall clinical picture,
they would want the
main pancreas as well. So that's our practice as well. We do in those cases. Whenever you are doing a FNAF to different places, you should use a separate needle for two locations.
One thing that's happened now is more often now I'm seeing patients who've already had PET scans by the time they come for their FNA. And so when they've got their lesions elsewhere, if they are already confirmed on PET scan to be positive, then they just want the biopsy from the lesion to see what kind of cancer it is. So in that case, there's total confirmation that this is metastatic disease, and really, I'm not sure whether it's worth doing FNA on the metastatic area, but main lesion always.
So it's easier to get a PET scan. That's what you're saying. They usually come up.
Because the oncologists are the ones that are sending patients to us mostly.
Okay, and they already had a PET scan.
So
Okay.
the patients all worked up, and then they decide, oh, well, wait a minute, this patient cannot be operated. They need chemo first, so then they need a tissue diagnosis.
Tissue. Okay.
When they need a tissue diagnosis, that's when we get them.
Yeah, I'd say our practice is obviously because of different region and different facilities. Usually these patients have some sort of symptoms. They all get a CT scan. What I usually say is the system, the VA system, medical, legal, and all that stuff. You walk to the ER with the toe pain and you get abdominal CT on that. So this is it's so common now.
Gradually coming there.
Yeah, so it's just I think a waste of resources, such a waste of resources. A little bit abdominal pain, everybody gets a CT. So what I'm saying is majority of these patients, actually pretty much almost all of those already had abdominal imaging done. They see something or the clinical picture is consistent with the malignancy, especially the pancreas. They come for FNA for EUS, and then they usually get the PET scan. I haven't seen a patient getting a PET scan first and then the tissue diagnosis. Yeah, it's really, I think it's just because the way the patient present and who they present to, that's what it is.
It's now become freely available for free, so it's a free service available in Karachi.
In free PET scan? Yeah, okay.
More and more people get it because of the cost.
Okay. So I think these are the two things I want to talk about before I go to FNA and FNB.
One of the things that I must say here is that you need to tell your chest colleagues and infectious disease colleagues that when they want their biopsies done of mediastinal lymph node, they don't need to send them to thoracic surgeons because I've still seen patients getting VATS and all whatnot for mediastinal and when the CT scan is not able to do a biopsy, then EUS is almost always successful.
Okay. So you can't do anything with the radial, right? Yeah. So yeah.
Even for mediastinum, you can't do the biopsy for the FNA, the radial.
Radial is never for FNA. It's not. You don't see the needle. You do see a needle as a pinpoint because it's just going in front of it, and it's not in the plane of EUS imaging. So any time a needle has to go in, it's going to be linear. Okay. No, you cannot do that with a radial. If you got to do a biopsy, obviously it has a working channel, and you can put a biopsy forceps through that. And I usually use a pediatric biopsy forceps if I got to just do a regular biopsy. But needle, no. Okay. Okay. So when I really trained in EUS, that was in 2008, 2009, the only needles available were by Cook at that time. And after that, there's like now a huge industry of needles. Boston makes it, obviously Cook makes it. Then there's Medtronic. I don't know, you heard about the Charcot, which used to be a beacon needle. And then the Olympus, and there are other companies as well. So there are so many needles available, and I don't know what. Do you have access to Boston?
We have
Cook.
access to Boston, we have access to Cook, we have access to Olympus,
Olympus. Okay.
and there's one other company that has just come, I think it is from Korea.
Okay. Yeah, there are so many needles available. It really is depends.
I can't remember. We use by and large, I use Boston.
And I think
Reference is Boston. What about the book?
I use Boston, Cook. I mean, if you give any needle, you'll be able to put a needle through it. That's not a problem. But we have Boston. We've been comfortable with it, and so we just continue using it.
You have more experience with Boston.
Probably cost are almost same.
okay. For my personal, I think any needle which is workable should do the job, and what you are used to and what is accessible to. You can work with any needle. So it just really depends on the what is available to you. Obviously, two different type of needles. One is FNA, final aspiration, and then FNB, fine needle biopsy needle. Based on really what you need, how much tissue you need, what you are biopsying, you can choose that. At the same time, cost is also is a big consideration in certain part of the world. So really choose what is available to you, and what is the affordability for you to do that, and where the lesion is, and also based on cytopathology services. I'll come to that. And so there are different factors that helps you choose a needle, whatever needle you need to choose. This is another needle. I don't know if you have access to this yet or no. This is a Olympus needle. You remember used to have the older version, and now this has an indication as a core needle as well. So it's a FNA and FNB needle at the same time. Yeah, so pretty much you can use for both purposes. Its sheath is a little different. It's a metallic sheath, kind of, and very flexible. Which needle we use? Just regular needle, injection needle. You use Olympus or Carlock, or which needle do you use here? Just like regular injection. Yes, sclerotherapy or semi-mucosal.
Whichever is available.
Okay.
Usually, again, in my case,
So you
mostly Carlock or which one is the other one?
Olympus needle is there. I think Boston is there as well, and
I don't use Boston needle so much, but so Olympus is more available. So
oh, yeah,
depends
yeah.
on what the hospital actually gets.
The reason, yeah.
Our thing also depends on what availability. No, there is a tender that goes, and the hospital then selects between the two costs. So we don't get involved in that. So whatever comes out.
So the reason I brought that up is like Carlock needle is very, very user friendly. It goes through everything pretty much. It doesn't matter what the position of the scope is, it's easier. And the same thing is with the Olympus needle as well. And it's very hyperechogenic sheath. It's not a plastic sheath, and hyperechogenic needle. So especially this new needle, that's one of the needles sometimes I've used. I use I have all three available. Either it's acquired or it's a Shardcore and Olympus. So it really depends. I think maybe sometimes who is there. Anyway, so what is the purpose of FNA? Obviously to get the tissue, and what do you desire in a tissue? Obviously it should be cellular, that's the main purpose. It should be enough to do ancillary studies, whatever you need to do it later, just sometimes for the genetic purpose, sometimes for flow, sometimes for immunostaining, whatever needs to be done. So there should be an adequate tissue. And ideally should be one needle. You don't have to use multiple needles in that. And what you don't want is too much blood in there. Okay. Difficulty of level of FNA. All the FNAs are not the same. Just remember that. And straighter the scope, easier the FNA. So the most easy one FNA is the transesophageal. Maybe a little bit more scary for us because we are not used to mediastinum. We like more anything in the abdomen is easier and a little more reassuring. But and in the mediastinum, heart, aorta, all those big vessels are closed, and you may not be comfortable. But that is the easiest FNA to do that because your scope is really, really straight. And then in the stomach. Could be liver, could be left adrenal gland, could be a pancreatic body, neck, and then head of the pancreas. I think some people think uncinate process is the hardest, and I think sometimes the submucosal masses are just painful to biopsy those. So I think I will put those both together at the same level of difficulty. For the uncinate process, sometimes you have to majority of the times you have to straighten your scope. And scope tends to slip back into the stomach. What you can do is you can ask your tech, especially in that position, to hold the scope for you. And there's no like that doesn't indicate that it's not your weakness if you have to ask somebody to hold the scope for you for FNS. So please, if that makes it easy and safe for the patient, makes it easy for you, makes it easy for the patient, please utilize another pair of hands or another hand. I'm going to come to that. Okay. So this is just an area of level of difficulty. Okay. So this is the reason. Look at the scope, upper ones here. How is the scope? Scope is really straight. Needle is going to come out really, really straight. So when you go into the head of the pancreas, it's kind of a U shape because you're resting in on the greater curvature. Scope is quite stable still. But look here, when you're in the uncinate process, what the scope position is, needle has to go in, make a U-turn, and then you have to target that. So that's why these are the major reasons why it's more difficult in theirs. A little bit about the definition of samples. Cytology is really mainly individual cells, or a group of cells. That's what you need. Cell block, we send that, and that is the tissue you get that is placed in the preservative, goes to the lab, they centrifuge it, or what we call the spin it, make pellets out of that, then make the cut those, and then make the slides and stain those. So that is the main tissue which they can save it for later use as well for immunostaining, or they gotta send the slides somewhere else, they can send that for a second opinion. If they gotta do some other studies on that, they can do on that. So what is core as compared to core is a tissue which has really a retained architecture, what we call not only the cells, desmoplasmic reaction to the tumor, and that is also architecture is retained, and that helps you do even more studies on that. So this is and the other key issue is in our unit we have a cytotechnician on site, which is our cytotechnician who do last year we did 4,000 EUSs in a year, and that is the second largest in the world and largest in United States. So there's one unit in South Korea that is number one. They do the most EUSs, but we did 4,000 EUSs. So you can imagine that we are almost doing 20 cases a day. And with that, even if 5%, if 25% of those are FNAs, still you need a person sitting there. So we have our own cytotech, which is, we pay for that as a unit, not the cytopathology, not the pathology services. So that is not obviously the case with every unit, not even in the United States. And they have to call the cytotech from the lab, and then if they need a cytopathologist to take a look at it, some is they teleproject the microscope to their pathology, or the pathologist has to come. So it's not easy, and it costs more money. Obviously, that has proven that it does increase your chances of having a positive specimen. But it's not inexpensive. And this is what we call a ROSE, and that's the main purpose, rapid on-site evaluation. That's one thing if you have available. Other is the cytopathologist available in the hospital? That is also very helpful, if at least they are available and you can call them and need. And the third is, which is majority of the cases, especially maybe in this part of the world, is that you don't have really accessible cytopathology services. Okay, so all these factors matter. All these factors help you choose what type of needle you should be using. Okay, so these are the studies which did show that really having on-site cytopathologist does help. But lately, after the availability of the core needles, and there's a meta-analysis that is kind of questioning, is there really a need of ROSE, or there is really a need of having a cytopathologist cytotech in the unit. If you have a cytologist or cytotech available, then you can make the slides right then and there, send the rest of the specimen for cell block. If, however, you don't have that, and you can get the specimen just for cell block, take a look at the specimen visually and make sure that looks like there's enough white tissue in there, not just all the clot red. So when you start seeing the white tissue or white stuff embedded into the clot, that's your real tissue. So that means you have enough of that. Okay, you can send that. And if, however, you have to send the specimen, I think you guys send it to Aga Khan from here? Shaukat Khan. Okay, so that goes to Lahore? Okay.
From here, there's a collection point they have here.
Okay.
We have direct access to the cytopathology department. So when the report, they know that our specimens go there.
Okay.
From here to Lahore, they send them.
Okay.
And then once they've looked at it, they have direct access to us, and we have direct access to them.
Okay. And so that also, in that case, obviously you need to make sure you have enough specimen. And I think you're making slides anyway here. Majority of the time you're using FNB needle for solid, or still FNA? FNB needle, so that's okay. So I will come to that, just like what is based on location and based on what type you need, what needle you should use. So fanning, I think we already know what that means. It means like you don't keep digging into the same place over and over, because that once or twice you go in, and after that it's really a blood in there, nothing else there. Suction, no suction. And there are different type of suction. One is the dry suction, then there's a wet suction. Wet suction, anybody knows what that is? Put the fluid in the needle and then use that as a suction. You put a suction on that and then use that as a like a wet suction. Slow pull technique, and then style it, no style it. There are different studies, some in favor of suction, other in not in favor of suction, especially for solid. So really depends what works for you. They both work. Dry suction, wet suction, whatever you want to use, both work. Then there is a stylet pull technique. Every time you go in, use a stylet, and the tech holds it, and that kind of creates a vacuum. You can use that. There have been studies both ways. The stylet helps, stylet doesn't help. The way we do it, because the needle comes with the stylet, so we use that in the first pass. The basic concept behind that was, when you go through the luminal wall, there's going to be tissue stuck on that, and you push that out with the stylet, and then do the FNA, but it really doesn't matter. It has been proven you don't need a stylet, and either way, whatever you want to do, you want to use it, well and good. If you don't want to use it, doesn't really change the outcome. So the needle comes with the stylet. I use it for the first pass, and I don't know if you noticed that the other passes I really don't want the stylet in there because it just takes time. Okay. Number of passes, this is the old one, especially when the on-site evaluation, if it's not available in those cases. But now if you have a diagnosis on first pass, why you need to make a 7 passes there? Bottom line is, like, after 7 passes, if you are not having a diagnosis, though your luck is, and the chances that your luck might work are really, really low, especially for pancreatic ones. Lymph nodes, you really don't need more than 3-4 passes on that. But if you have you're making slides there, taking a look under a microscope, you have an on-site cytopathologist available, you look at the specimen, there's a good tissue in there, you don't need that many. We already have talked about that. Very, very safe technique. Risk of bleeding or pancreatitis or infection, all this is low. For cystic lesions, whenever you do FNA, you should give antibiotics. That decreases the risk of infection. Usually the way we do is we use Cipro majority of the cases, unless they're allergic to that. Give one dose right during the procedure, and IV, and then give them 3 days, 500 milligram BID for 3 days. Some people use it for 5 days as well, but we usually use for 3 days, and that's only for the cystic lesions. Okay, so this is I think you have seen enough of this. You see that this is a kind of a nice like a ring or target lesion there. That's very consistent with the metastatic lesion. And majority of the times you're not going to see the metastatic lesions like that. They're really, really subtle, and you have to have an eye to look for that. And you have to be very careful. Okay. So here, this I think this was a patient with the pancreatic mass and also liver met. Question earlier asked which one you would do. As I mentioned earlier, that I usually end up doing both. And here, I don't know if you're going to notice that when the needle goes in, you see that the needle is not in the center of that lesion. Why is that? I'm intentionally going to the side. Cystic area, and it's all necrosis. It's all dead tissue. Even though you want to go into the center, makes you feel better that you are right into the lesion, but you're not getting a tissue. The best place to go is really the periphery. That's the way mainly the viable cells are going to be there. So try to go, and it's sometimes easier to really go into the periphery. And I don't know if it's a FNA or FNB needle. It looks like a FNA needle. That's why I'm doing that many passes, because FNA needle, fanning technique, you remember, like 4 times 16, like you go in one place 4 times, then you change, go 4 times, change 4 times, like usually it's 16 times in and out. FNB, you really need to go only once in one place, because what you do is with the FNB, you kind of is like you're boring it, and once you go in, that tissue is out. Second time you go in, It's just got just blood in there. So there's no purpose of going. If you want to go in the same place twice, it's just like, don't go more than twice. Second time is okay, but after that, you're going to see it's a white hyperechogenic line in there, which is only blood. Okay. So for FNB, you really don't have to go 16 times. It's really only 4 or 5 times. So these are the slides showing that you get a tissue, good tissue. For metastatic lesions in liver, they are extremely, extremely cellular. And usually I end up using 25 gauge needle for those because they are so cellular and you get a very, very good specimen with that. If you're doing 3 passes of suspected MET in the liver and you're not getting a tissue, your technique is fine, you're in the lesion, still didn't get a tissue, I doubt that's a metastatic lesion. It could be something else. It could be a hemangioma, it could be a focal fatty sparing, and so it probably is not. But if there is a metastatic lesion in the liver, you should be getting positive in probably first steps at the least a second or third, but beyond that, if it's still not getting it, then probably it's not. This is another example of on the same area, the necrosis, what I was, even though this lesion is so big, it's very tempting to go right into the center, but you see that I'm pointing at that the necrosis right in the center. So avoid that. Don't go there. Go to the periphery. You can go either on this side or can go on that side. Yeah, that theoretical risk is always there. There has been a study, I think it was, I don't know how, it was a few years ago. They did it very cleverly. I think they got a specimen from the portal vein after the FNA, and you can find malignant cells there. So just doing a FNA, you're spreading the cell, kind of. There's a slight risk, possibly a risk of spreading those. I don't know, I didn't see it published. I don't know what the status of that was. Seeding, if you, there is a very, very minimal risk. Theoretically, it does exist. If you are accessing the pancreatic mass via duodenum, that doesn't matter. Because if they're a surgical candidate, that's going to come out. Okay. However, if you're going through the gastric wall, that doesn't come out with the surgery. So theoretically it is there, but it's so minimal that we don't even care about that. And in some countries, I think especially Japan, they are very, very careful about that. It's like if it's a lesion in the pancreas, it looks resectable. Some people may not do a FNA. But the problem is, if it's a lymphoma, then you send a patient for surgery without having a tissue diagnosis. But in our part of the world, in the United States, and I think here as well, surgeons want a tissue diagnosis. Oncologist wants a tissue diagnosis because pretty much every patient nowadays ends up getting either neoadjuvant before the surgery or after the surgery, they end up getting some sort of chemo or radiation. So theoretically, yes, but practically, no. Okay. So, but yeah, that's a good question. Yeah, that theoretical risk is always there. Okay. This is you look at the tissue Y core biopsy, and it's just a little extreme. If you're using a FNA needle and getting this, probably change your technique. It's not needle's fault, and so core can give you a more specimen. There have been these are the FNA needles. Even though it makes sense, like bigger the diameter or bigger the gauge would give you a better tissue or more tissue, but that is not true. And 25 gauge needle is even better than 22 gauge needle with regard to the cytology specimen. This meta-analysis is not really, does not take core needles into account. It's just a FNA. If you're doing FNA, 25 gauge needle really gives you a good specimen for that. This one is from our center, this study, and this is a study on a retrospective 4-year EUSs. I think get 10, less than 10 minutes. That's fine. You can go ahead and start, bring the patients, and we will get to work. Okay. So this is a study from our unit, 4 years, over a period of 4 years, retrospective. And 2014, 2015, FNB needle wasn't available, so we were mainly using 22 or 25. And then after that, majority of the time, more than 90% of the time actually, and some of my colleagues, they were 100% of the time using only FNB. I was using in a different way, majority of the time FNB, but based on the location, based on the lesion, and I might use FNA as well. So 2014, 2015, 22 or 25 gauge FNA needle, and 2016, 2017 FNB needle. And if you look at the FNAs over a period of 4 years, almost 3,000 FNA or FNB, whatever you want to call it. Majority of those were FNAs, 70%, FNBs 31%. And what it tells you, like we had on-site cytopathologist rapid on-site evaluation with the FNA needle. Median number of passes required to get a positive rose was 2. This dropped by half just with one pass, median pass 1 with the FNB needle. And also diagnostic yield of cell block, not the cytology right in the room, or not the rows. Diagnostic yield of cell block was much better with the FNB as compared to FNA needle. So main thing is, conclusion is like really if you don't have a on-site cytopathologist available, then it's better probably to have a better luck with the cell block, use a FNB needle. And with that needle you have enough tissue for ancillary testing and molecular profiling as well. And now this meta-analysis comparing FNA versus FNB in submucosal tumors. It's not like other tumors, submucosal tumors. FNB appears to be better than FNA needle. And this is same. Then this is a different meta-analysis. Needle type mainly for the pancreatic tumors, 27 studies. This meta-analysis, because a lot of studies were older ones on FNA needle, and according to this really needle diameter or needle type, be it FNA or FNB, does not make a difference. This is important one. I want to show you the video. What I was mentioning earlier is we tend to forget that FNA and FNB are totally different techniques. And with the FNA, as I mentioned, those 4 times by 4, total 16. But FNB, when you take a look here, and other thing is, I hope I kind of showed in this video, but let me take a look when the needle comes in here. One thing is, so you see that I'm looking at that area. You see the needle gonna come in there. Okay, I'm gonna stop it here. Okay, I'll go back a little bit. So the important thing is, this is the lesion, right? This is the intestinal wall right here, gastric wall. Remember that the muscularis propria in the gastric wall is quite strong, and sometimes it pushes you away or it slips off. And especially if you didn't move the stylet back by mistake, then it's never gonna go in. So one thing that I say is like, get the needle out. Needle should be at 90 angle, if possible, to the lesion. At 90, it's just like straight, and needle like it's a floor, and the needle should be right straight at 90 angle. Okay, that's one thing. Second thing is, you get into that. Don't go crazy and just like you just want to get in there. So get the needle out slowly, get onto the wall, get the needle embedded into the mucosa. Needle comes out of the scope, it goes onto the wall. When you gently push, gently take the needle out, touch the mucosa. When it touches the mucosa, it kind of makes a divot in there, dip in there, and so when that happens, it's like this, a little bit divot in there. That means your needle now is stable. It kind of is holding the mucosa of the wall now straight. After that happens, then you do what a quick or safe stab is like this, a quick. Because if you do it slowly like this, you're never going to get through the wall. Okay. So it has to be quick, but at the same time, it has to be safe. Don't go through the, from here all the way through the, splenic vein and maybe some other place on the planet. And just that's why it has to be really, really controlled at the same time. Okay? So don't let the needle from 1 all the way to 8, 8 centimeter.
Do you recommend for the beginners measuring the span and then adjusting?
Yeah, you can. Yeah, absolutely. That's what's going to be my next point. If you are afraid that you can't control the needle, then what you can do, that stylet locker, the needle locker, you can just put at 4 centimeter and lock it down. You won't go through the pancreas with that when it's 4 centimeter. Keeping in mind you need 1 or 2 centimeter really to indentation of that wall. So it's going to be 2 centimeter more than that to go in. You can lock it, and then you have a good control. Keep in mind, do not forget that your stylet is locked. The lower button on that, the one which locks the stylet, the lower locker. Because if that is open, your stylet is going to go first, and then your needle is going to go. So that's going to be very, very dangerous. That could cause a perforation as well. So gotta make sure that your, not the stylet, I mean the sheet. I'm sorry. The sheet is, that's what I'm doing, the locker of the sheet. That is really, really locked. Okay. So that check every time you do a FNA. Maybe your cap opens up there by mistake while they're pushing the specimen off. Sometimes that happens. So every time I put a needle onto the scope, I make sure that the locker for the sheet is really, really tight.
This is the
Complete.
lowest one. Yeah, this is the low.
Lower one. Because sometimes that opens, especially with the Olympus needle. They don't lock it. I have told them that the company, they need to lock it, start locking it. They don't for some reason. And but the Boston, the Cook, I think.
And also, Khalid, just a warning, because when your tech actually takes the specimen out, sometimes they would change the settings, sometimes they don't, they forget to, they open it up and then they don't lock it, etc. So
Yeah.
every time you go back, you must make sure.
And here, did you just take a look at that? How, with what speed and with what control the needle goes in? You see that? You see that? It just, and that's going to help you get through. The lesion does not move a millimeter, and the needle is in. Okay. Yeah, and look at that. When you get in there, don't come out when you are doing like fanning. You see that how I'm changing the direction of the needle? Fanning is with, first thing is with the wheel, second with the scope moving in or out, and then you can use the elevator if needed, but don't use the elevator when the needle is here. Use the elevator when the needle tip comes really close out, because otherwise your elevator is not going to work. Okay? So this was only, okay, I'm going to stop here. This was only like 4 back and forth. So that's different than an FNA needle. FNB, less tissue, less movements in and out. Okay, let's go.
Who's Dr. Kashif and? The other person? Sedation में कर रहे हैं ना? Khalid can take the propofol one, I'll take the sedation.